Hello, everyone. Welcome to RT's webinar on preventing VAE and ventilator-associated pneumonia. I'm Mike Fratantoro with RT Magazine. This webinar today is sponsored by Draeger. Stay tuned for a message from them. You can learn more at www.draeger.com. Here's a look at who's on today's panel today. We have Marie Madden. She's with the Intensive Care Online icon. She's also the AARC Adult Acute Care Chair. We also have Gary Kaufman from Kaufman Consulting, LLC. He's a respiratory therapist and author. And again, I'm Mike Fratantoro with RT Magazine, the chief editor. So here's a look at our program for today. We're going to, obviously, we start with introductions. Then we'll start with Maria Madden on her presentation. Part 2, we'll go to Gary from the financial implications of VAP. Part 3, we have moderated discussion with some questions that I have prepared. And then part 4, we'll open it up for audience Q&A. So there is a function on your dashboard there. You should be able to submit questions to our panel. And we'll get to as many of those as we can in the last 10 to 15 minutes of the program. So part 1, we're going to talk about some strategies to prevent VAE and VAP. We're pleased to welcome Maria Madden. Maria has been a respiratory therapist for over 30 years in various roles as an RT, an educator, research coordinator, supervisor, and ECMO specialist for the University of Maryland Medical Center, Adams Cowley Shock Trauma Center, and a clinical specialist for ICON, the Intensive Care Online Network. Maria is currently the chair of the Adult Acute Section for the AARC and a clinical specialist for ICON, and also an instructor at Radford University. Maria, thanks for joining us today.
Thank you so much. It's exciting to be part of this. I'm very honored also to be doing this discussion on VAP with Gary Kaufman. Thanks again, everyone, for joining us. And as you could tell today, we're going to be talking about ventilator-associated pneumonia. Disclosures, I just want to say I have been sponsored by Draeger and ICON for lectures. All right, so what is VAP? So ventilator-associated pneumonia is a pneumonia that is acquired after intubation in a patient that's on a ventilator greater than 48 hours. So why are we discussing this? Because the mortality rate back in the early 1990s, what we're going to talk about, was pretty high related to VAP. So back in the 1980s, VAP was actually reported to occur in 28% of our vented patients, with the highest rate occurring early in the course of intubation. It was actually estimated that 3% per day, the risk went up for developing VAP up to the 5th day. So VAP was not only the most common ICU-acquired infection, but it had a mortality rate that has been reported as high as 50%. And with at least 25% of these patients' deaths were actually contributed to the infection and not the patient's underlying disease. Luckily, most recent studies have showed a decrease in mortality with VAP because of everything that we have done. But VAP still, there's an increased mortality, morbidity, hospital stay, and the cost that Gary's going to talk more about. So the recent data is actually showing that the rate of VAP is 5 to 10% with our vented patients. And the estimated mortality rate related to that is about 10%. But it does vary considering the type and the severity of underlying illness of the patient. So both VAP and ventilator-associated events increase vent-As, and as we all know, that means increasing our ICU stay or hospital stay, and that all increases the cost of our hospital stay. That, as I said, Gary's going to talk more about this. So as you can see, in the last 2 decades, we've been busy with guidelines to help propose ways to reduce the incidence of VAP. It has been proven that interventions, and when we combine them all together, they're useful and successful. And as we're bundling these strategies up, I also think it's helpful to making sure we're getting them all done. So the first consensus statement on hospital-acquired pneumonia was back in 1996 by the American Thoracic Society. So then you can see all the guidelines that came after that. And we're going to focus on the recent guidelines in 2022. So we're reviewing the strategies to prevent VAP from this article titled Strategies to Prevent VAP, Ventilator-Associated Events and Non-Ventilator Hospital-Acquired Pneumonia in Acute Care Hospitals in 2022 update. So this is very recent. And this was put together by the Society of Healthcare Epidemiology, Infection Disease Society of America, the Association for Professional Infection Control and Epidemiology, and the Joint Commission. There is also major contributions from representatives of number of organizations, and we do have a respiratory therapist involved in this, Richard Branson. And I always love seeing respiratory leaders involved in guidelines, especially when they're including respiratory recommendations. So this was actually published in Infection Control and Hospital Epidemiology in 2022. So the purpose of this document was actually to highlight practical recommendations, things that we should be prioritizing, implementing at bedside to help us to prevent VAP or reduce the rates of VAP and ventilator-associated events. They do review strategies in this article for adults, peds, and neonates, but we're going to focus more on the adults. So as you see here, these are some of the prevention strategies that have been recommended, that we've been doing in the past to help us with VAP, and that we're going to review. I do want to say it does require a multidisciplinary team to work together to decrease and decrease VAP. So the committee recommendations were organized in essential practices. We're going to review those that we should be doing at bedside. Then they offered additional approaches, and then things they do not recommend. With each recommendation, there's also a state of the level of evidence. So the first one, avoiding intubations to help avoiding intubations and reintubations using high flow nasal cannula and non-invasive ventilation. So this was added to the recommendations to help us decrease the chances of VAP, of course, by preventing the patients actually getting on being intubated and on the ventilator. And I feel this is something we've really gotten really good at lately, especially since COVID, that we've been really working on these strategies. And as RTs, we should know which therapy would benefit our patient. And these two items have actually been a pretty hot topic in the ARC Congress. This past year, there's a lot of publication and research studies that have been published on high flow nasal cannula and non-invasive. There was actually also a recent article in our respiratory care journal discussing even combining these two therapies together to minimize intubations. And the quality of evidence on this is high. So if we have to intubate our patients, let's elevate the head of the bed 30 to 45 degrees. It's just always been a recommendation. There's data supporting this. Studies have shown significant reduction in VAP, but showing differently in vent days and mortality rate. So not seeing much in the benefit in decreasing vent days and mortality rate with it. So that's why the evidence is low. We also know gastric reflux and aspiration can lead to VAP in our vented patients. So again, this is another reason to keep the head of the bed up to help reduce acid reflux and potentially decrease VAP. So you think this makes common sense, but I have to say again, back in my day, intubated patients were placed in the supine position. So a lot of these studies actually are comparing patients in the supine position and the head being elevated. And I just want to say, Gary had a great story about this. All because the patient's bed is elevated doesn't mean your patient is in the right position either. So, you want to make sure that the patient's also sitting up in the right position and not just slumped down in the bed. And of course, the only exceptions to these are, are patients that have medical issues that require to be supine. The next one is minimize sedation. So again, we can't avoid intubation, so why not work to minimize the duration on the ventilator? Trying to minimize sedation so we can be aggressive then liberating our patients from mechanical ventilation. As RTs, we should be discussing with the RN when we feel maybe the patient can be weaned a little bit from their sedation so we could start allowing these patients to do some spontaneously breathing. And we know there's current strategies in this. Nurses have nursing-driven protocols to target light sedation and daily sedation awakening trials so that we can do our SBTs when appropriate, again, for patients without contraindications. And I also want to say, we all know ventilator weaning protocols will help liberate our patients faster. So if you don't have them, consider developing them. We need respiratory protocols. The next list of essential practices is, top one is providing oral care, and then also brushing our patient's teeth daily without chlorhexidine. And this is a moderate clinical evidence supporting this. So we all know oral health quickly deteriorates with our vented patients. Some of these patients also may sustain some injury from us during the intubation or after the intubation, and they're prone to having dry mouths. So all this contributes to the chances of these patients increasing bacterial colonization, which then increases the risk of them developing infection. So adequate oral care helps reduce overgrowth and reduce the risk of infection. So as I said, this is a moderate recommendation. Daily brushing of the patient's teeth has been associated with a decrease in VAP, shortened duration of vent days, and shortened ICU stay. There are studies that have shown that RTs assisting with more of the oral care do help decrease VAP as well. And I know several hospitals that I talked to several RTs this week that the RTs is part of their requirement there that they're also doing oral care with these patients. So the next one is changing the ventilator circuit only if needed. So there was a large observational study that looked at changing the circuit at 2 days, 7 days, and 30 days. And the highest VAP rate occurred at 2 days, and the lowest was actually 7 days. So the recommendations is change the circuit when it's soiled or malfunctioning, or the recommendations of your manufacturers. Stating it is important because because back in the day, again, I have to say, I used to change my circuits every other day. We use a lot of the reusable circuits. So again, it makes more sense just trying to minimizing breaking the circuits. Maintaining improved physical conditioning, a moderate recommendation. And as we know, early exercise and mobilizing our patients does decrease vent days, ICU length of stay, and it does lower VAP rates. And this helps then also increase the chances for the patient to returning to them being independent functional a lot quicker as well. Again, this is another hot topic. We had lectures this past year in Congress on this. Our president of the ARC, Carl Hickinson, actually has done several presentations on this. But there's no consistent association between early mobilization and a decrease of hospital length of stay or mortality. Financially, this is also has been suggested that early mobility programs may also be cost savings. So as we know, early mobility can be challenging, especially nowadays we're short-staffed with RTs and RNs, but we know how important this is for our patients. Again, decreasing VAP and decreasing vent days. And it's all about our patients. So we should try to be helpful working with our multidisciplinary team. Sometimes it might be just you with the nurse trying to get the patient up at the edge of the bed, so the patient's maybe just dangling their feet or getting them in a standing position. And for some of those patients that are more high level activity, why not walk them? We used to call it the bag and dragger patients. Nowadays, if we're walking our vented patients, we're taking the vent with us. That's how we're going to see the best outcomes. The last one on here is provide early enteral versus parental. And I think I lost you guys. Are you guys there?
Yeah, we're here. We still see your screen and hear you.
Okay, because I don't see my screen anymore. Let's see. Okay, I don't see the screen.
Okay, yeah, you're still on the essential practices slide with provide early enteral versus parental nutrition. I can advance them for you if you wish.
Yes, that'd be great because I don't see them. Okay. So early enteral nutrition is associated with lower risk of nosocomial pneumonia. Again, shortening the ICU length of stay and shorter hospital length of stay compared to those receiving parenteral nutrition. And the evidence is high. All right, next slide.
Okay, additional approaches.
Okay, additional approaches. So ET tube with subglottic suction is under additional approaches and is no longer considered an essential practice. So we know the drainage of secretions collected above the cuff of the ET tube has shown significant reduction in the incidence of VAP, and great to use if you know your patient is going to be intubated greater than 48 hours. I know several hospitals, again, talking to respiratory therapists this week in different states, that is the standard of care. And the suction can be applied continuous or intermittent, but no study showing that one is better than the other. So the meta-analysis study that actually demonstrated a reduction in 44% the rate of VAP with these patients when we're using the subglottic suction ET tubes, but there was no significant decrease in vent days or ICU length of stay. So again, I think this is why it's moved over more to the additional approaches. I also want to say though, if you don't want to be changing ET tubes just to put one of these in, again, we know the risks of reintubations. Next one on the slide is consider using selective decontamination of oropharynx and digestive tract to decrease microbial burden in ICUs with low prevalence of antibiotic-resistant organisms. This is a high recommendation. I currently work in an ICU that has high prevalence of antibiotic-resistant organisms, and I'm assuming many of you as well, just thinking because of COVID, might actually be still implementing this. The last one here is considering early tracheostomy, and it has been associated that if we do an early trach within 7 days of intubation, that we can actually decrease the rates of VAP 40%. So again, who would we do an early trach on? And these are kind of patients that it made me think of my trauma patients or spinal cord injury patients, maybe our traumatic brain injury patients with injuries that we know they're going to be on a mechanical ventilation for a prolonged period of time. And this is something the provider will be discussing with the patient and the family. Next slide.
Okay, generally not recommended slide.
Okay, so generally not recommended. So I'm just going to touch some of the ones that I think are important for us. The top one is automated control of endotracheal tube cuff pressure. So we need to monitor cuff pressures. There's been studies that have looked at patients that had tracheal tube cuff pressures below the 20 centimeters of water pressure, and they had higher incidence of VAP. So it's important that we maintain the cuff pressure above 20 to minimize the aspiration risk, but making sure we're below the tracheal mucosal capillary perfusion pressure, so we're not to minimize any tracheal erosion. But so this is over here as a not recommendation of automated control, because there's been studies that looked at frequent versus less frequent cuff pressure monitoring, that manual measurements of cuff pressure is associated with loss of cuff pressure and potentially leakage of fluid around the cuff. So there's not a lot of data actually supporting automated control of ET tube cuff pressure or the increased frequency of cuff pressure. So usually we're doing this once a shift. The other one I think that's wanted to mention in here, the oral care with chlorhexidine. It's interesting to see this not being recommended anymore. And it states in here that the meta-analysis reports show significant reduction in VAP, but the signal is driven by unblinded studies. So there's no association between oral care with the chlorhexidine and lowering VAP rates when the analysis was restricted to a double-blind studies. So this is really interesting. The rest is just going through the different ET tubes out there, the ultra thin ET tube cuff, the tapered ET tube cuff, silver coated ET tube cuff. There's not enough data supporting using these in the reduction of VAP. Kinetic beds, prone positioning, we're using it for ARDS. There's no data supporting that it's decreasing VAP. And then the chlorhexidine bath. And I think that's you want to go to the next slide? I think that's my last one.
Yeah, that was the last one.
So right there is what is the current recommendations in VAP. And I think it's a good idea as therapists, looking at our recommendations, looking at our involvement, and what else can we do at bedside to assist in decreasing the incidence of VAP and ventilator-associated events. And I will turn it over to Gary.
Okay, thanks, Maria. We're going to have a quick break for a message from Draeger. Okay, this educational webinar is brought to you by Draeger. Draeger offers some of the most innovative medical devices and systems available, including advanced ventilation workstations, software packages, smart accessories, mobile monitoring, and clinical information solutions. With their long history in ventilation, Draeger is committed to advancing the practice of respiratory care through education, research, and clinical practice. For additional information, please visit www.draeger.com. So we're going to move on to part 2, the financial implications of VAP. With that, I'm going to introduce Gary Kaufman. Gary Kaufman is the founder and manager of the healthcare consulting company Kaufman Consulting LLC. Gary has more than 40 years of experience as a respiratory therapist, as a bedside clinician, educator, and administrator. He has served in several governance roles with the American Association for Respiratory Care and is an active speaker and author of numerous respiratory care textbooks and journal articles. Gary, thanks for joining us today.
Thank you for having me. That's the first time I saw a picture of me without glasses. I wonder where that one came from. So first, thanks to good folks at Draeger for sponsoring this. And secondly, thanks to now 170 attendees who get to listen to Maria and I share some thoughts. So first of all, I took notes when Maria was talking. Absolutely fantastic information. So thanks so much. So I'm gonna focus on the financial implications of that. First off, my name is Gary Kaufman. I'm the owner-manager of Kaufman Consulting. I'm a career-long respiratory therapist and AERC member, and I hope you are as well. I have no conflicts of interest with regard to the content of this presentation. My sole focus is talking about the numbers behind that. Well, maybe someone in this webinar is of this age cohort, but this was, as you can see, August 1978. The reason I have it there is not to show how young Dean Hess and I were back in the day, but to serve as an illustration. It really follows up on what Maria was saying. Hopefully we apply the best available evidence. And if you remember one of Maria's slides, it says these were the standards in 2005, 2010, 2016, now 2022. But they didn't used to be that way. What were we doing back in August of 1978? Well, we changed our vent circuits daily. Why do we do that? Because we could charge for them and the hospital got reimbursed. Did we think about VAP? Wasn't even in our lexicon in those days. We did what we did because we thought it was the best thing to do. Patients on a ventilator for a day, why not give them a clean circuit for the next day? We also counted how many times we suction. In some cases, we actually wrote that in the paper chart, if you remember paper charts. And we charged for the suction canisters. And I can remember a nurse manager opening a new box of suction catheters. These weren't the inline, these were where we had to break the circuit. And she counted, make sure it was 20, because at the end of her shift, she had to log how many were utilized, 20 minus whatever number was left in the box, and she had to check that those were charged for. It wasn't we didn't care, we really thought that that was the best way to practice medicine, and we got reimbursed for that. We charge for our supplies, from the syringe, the needle, the blood gas analysis, you name it. If we gave it, we charge for it. Those fee-for-service days are long past. So when we're talking about direct and indirect costs, what I'd ask you to think about is what we're doing evidence-based. Maria gave us a number of slides of supporting evidence or lack of supporting evidence. So we should be applying and utilizing our services that are at the highest level of evidential support. Don't worry about charges, don't worry about bills and reimbursement, that's someone else's area. So we weren't uncaring in 1978. We might have dressed funny, and I think I probably used Aquanet on that hair to hold it down. But we did what we did because we thought it was important to do for safe and effective care. And now we know a little bit better. Next slide, please. Now, costs, to keep it simple, there are direct costs and indirect costs. And if you think about it in this way, direct costs are those things that you see at the bedside. They're the direct services to the patient. Those services that touch the patient, from blood gas to mechanical ventilation to x-ray, you name it. The indirect costs, we can't forget about this because in many cases, the indirect costs are equal to or higher than the direct costs. So that's all that stuff behind the curtain, behind the scenes, that's necessary, from laundry and housekeeping, dietary, to the executive suite. Those costs we need to account. So every day that a patient is on a ventilator, greater than what they need to be, it's our labor and all that stuff behind, as I call it, behind the curtain. Next slide, please. Let's take a look at direct costs and what are some of the examples. On average, labor is 60 or 65, even 70% of the total operating expense of a hospital. So by far, we need to think about labor. Now that's a generic term for physicians, nurses, therapists, rad techs, med techs, PT, that infection surveillance nurse, that performance improvement person who's tracking these rates. So that's the biggest part of direct costs. Well, what about medications? Antibiotics, the medications that we use for bronchopulmonary hygiene, IV, cardiopulmonary medications, and the list goes on. Significant part. Supplies, bed linen, nutrition, disposables, the things that cost dollars to $100, maybe $200, but they fall under that capital limit of typically hospital use of $500. Now, you may not think about, you may not think, well, this doesn't add up to much money. What about beds and therapists and ventilators? Isn't that where the largest amount of money is? And the answer is not necessarily. If you use a ventilator circuit, inline suctioning, and blood gas kits and analytics, all of that can add up to a substantial, in fact, does add up to a substantial amount of money. And every time, and particularly for virtually all of us who are paid under a capitated system, the DRG system, it doesn't matter what we do, and I'm talking finance now, it doesn't matter whether we give one nebulizer treatment or 20, the hospital is reimbursed the same amount of money. So if a patient is on a ventilator and they're on 2 days versus 5 days versus 10 days, with some minor exceptions, the reimbursement to the hospital stays the same. So why is it important that we use soft cannulas, effective nebulizers, use protocols and ventilated patient liberation protocols? Yes, you can talk them, get a sip of water. It's pollen season in North Carolina. So it's important we do the right thing at the right time with the right supplies, the right capital equipment, because our reimbursement is capitated. We don't get credit, with a very few exceptions. We can't go back to Medicare, Medicaid, and the commercial payers and say, well, we didn't get the patient off the ventilator today. We're gonna leave them on through the weekend because we're short-staffed, we'll take them off on Monday. The payers don't care. The reimbursement is the same. Again, I'm not talking about safety and quality, I'm talking about finance, but if we do the right thing in the right way, we will have safe and effective care and do so more economically. Now, what's testing analysis? The lab, the imaging, the physician interpretation of those studies. Again, if a patient's on a ventilator for an extra day, think of the other tests and procedures and therapeutics that they receive. All of that subtracts from the bottom line, adds to the cost. So that's why managing VAP, reducing VAP, eliminating VAP is critical. Now, what's capital mean? Those typically are devices that are $500 and have a lifetime of greater than 3 years. And those factors vary by hospital to hospital. So let's pause here. Go back to Maria's slide about the lack of evidence to support kinetic beds. If there's no evidence that those beds reduce VAP, or VAP, why are we using them? They're very expensive to rent. Look at the evidence, and if we apply evidence in a judicious manner, we actually will be able to provide safe and effective care at a reduced cost. Okay, next slide, Mike. Now, what are the indirect costs? I mentioned that these are behind the curtain and you don't see them, but what about bed availability? Well, let's think about this. If your hospital doesn't have enough beds, now currently, the limitation may certainly be nurses and therapists as far as open beds. But pre-pandemic and hopefully around the corner post-pandemic, if your hospital is full, it may cause you to go on divert. So having the bed availability is important. The sooner that ventilated patient is liberated from the ventilator, is extubated, the sooner their ability to move out of ICU and make that bed available for another individual that needs that level of care. Support services, laundry, housekeeping, dietary, safety and security, environmental, all of those departments are indirect costs. So every day, for example, a ventilated patient is extended because of VAP, they are consuming not only those direct costs, but the opportunity costs. And I remember full well looking at opportunity is there an opportunity to reduce direct and indirect costs by using patient-focused respiratory care protocols? And the answer is yes. We've got hundreds of studies that show if we do the right thing at the right time with the right equipment and devices, we can reduce that. And I don't know about you, but I know I've worked in institutions where the call comes out to all departments, we're going on divert or we're going on to ICU divert. We don't have a bed. So we need to think about the opportunities to reduce the time the patient is on the ventilator, has a tube in his ICU, and what that means to the organization. Okay, so let's take a look at some studies. Next slide, please, Mike. I could have pulled up 50 studies, but that would have been 2 hours of lecture. So I'm gonna give you 3 examples here. The first is an article was written in 2005 in Critical Care Medicine, a peer-reviewed journal. And they looked at the clinical and economic consequences of VAP, a systematic review. And what did they find? Clinically, between 10 and 20% of individuals on mechanical ventilation greater than 48 hours develop VAP. This is in 2005, by the way. You heard from Maria, these numbers have changed over time. Those individuals who develop VAP have double the mortality. Patients who develop VAP have a higher ICU length of stay, which is kind of an obvious one, but it's important because when we're looking at the cost, the earlier an individual leaves ICU to go to transitional care or general med surg, the lower the operational cost, the less expensive that bedtime is. So in this case, those individuals who developed VAP incurred over $10,000 of additional hospital costs. So think about that. In your hospital, if you're getting paid a fixed amount, and again, I apologize for talking about dollars, that's important to talk about safety and efficacy. But in this section, when we're looking at money, it may be, in fact, it is worthwhile to the prophylactist to use those other devices and preventative tools and therapeutic interventions to reduce the incidence of VAP. Now, just to give you an idea what those are today in today's dollars, that increased 50% from 2005 to 2023. Next slide, Mike. This study was done in 2010, so about 5 years later after the first study, and they looked at the financial impact of ventilated patients who develop VAP. First is, and I made this slide to keep it a little clean. The first set of numbers are the costs and time, et cetera, for VAP. The second is non-VAP ventilated patients. So let's look at total hospital costs. For patients who developed VAP, their total cost was approximately $77,000 versus that same cohort of patients who did not develop VAP, their total costs were 41% or $41,000. So what's that? $35,000. That's something like an 80% increase in the cost because of one thing, and that one thing is VAP. The median duration of intubation was 10 days versus 4.7. That's a significant factor because not only have they developed a complication, but that is what over 5 days difference that they're intubated. With intubation, you incur additional costs. The median duration of ICU stay was 18.5 days versus 8 days. So the question I'll ask you is, if you are asking for more staff for mobility program or other preventative or therapeutic measures that Maria talked about, and you get pushback, to be blunt, that we can't afford that. We can't afford the extra RN, RT for mobility program. We can't afford the other therapeutic interventions. Show them this number, 10 days in the ICU, only because the individual developed VAP. The question I would have for you is, what does it cost your hospital for a day in the ICU? If you don't have that answer, talk to your finance folks to say, what's the average cost for an individual in the ICU? And if they can break it down, a ventilated patient in the ICU, even better. So the last thing is, how long were these individuals hospitalized? 14 days for the non-VAP, 26.5. So all but 13 more days, a day short of 2 weeks, the individual was in the hospital, purely because they developed VAP. The question I would ask before I close out this slide is, what do those med-surg days cost in your hospital? Is it $500, is it $800, $1,000? Ask finance for that number because it will help you justify your therapeutic interventions. Next slide, please. This study was done in 2017, and they looked at, again, hospital cost and mortality with different HACs, hospital-acquired conditions. And as you know, these are reportable events through the PPACA program. But I pulled up these 5. These are the top 5 to give you an idea of the magnitude. Adverse drug events, $5,800. Certainly we don't want any of those, but I think sometimes we think, boy, medication errors are far more expensive and prevalent, but it's actually the lowest of the group. What about CAUTIs and CLABSIs? CAUTI around 14,000, pressure ulcers anywhere from your buttocks to your face, 14.5, CLABSI 48,000. So CLABSI is the top of the list for the hospital cost. Again, not charges, and to reinforce, these are costs that are not recovered because for commercial, Medicare and Medicaid, with a few exceptions, they are on a capitated system. So where does VAP fall? 47,000 and change. Again, just to give you an idea what those numbers are in today's dollars. Now, this is 2017, so in 5 years, it went up over $12,000. So almost $60,000 in cost, today's dollars, for individuals who develop VAP. And next and last slide. We've all seen this quote, an ounce of prevention is worth a pound of cure. And I brought it up for us to conclude this section and to think about many times, whether it's a soft cannula, an effective nebulizer, a mechanical ventilator, a heated wire circuit, an antibiotic, a mobility program, ventilator liberation program. we're told we don't have the resources, we don't have the staff, we don't have the ability to do that. What we need to reinforce, one, come with the facts, and Maria's given us those facts for the clinical sequelae, the treatments, the prophylactic treatments, those that have high, moderate to high evidence of validation. I've provided the economic consequences of that. So this is truly one of those pay me now or pay me later. So just to kind of go back and kind of tie this together, what are the interventions that we could do to prevent that? Well, first of all, avoid the tube. Use NIV, HFNC. Second, Marie indicated, was to minimize sedation, ventilator patient liberation protocol, SAT, SBTs. I think when I think in my experience as a clinical respiratory therapist, I go back many, many years, more than probably anyone on this call, and our medical director said at the time in the ICU, I was a junior RT student at the time, he said, I want you folks to get that individual up and out. And I said to the nurse, what's that mean? She said, he wants us to put them on a bird, one of our green birds, they're 12 or 14, had automatic rate, and take them down the hallway. And I said, well, they're laying in bed. And I said, what's that gonna do? And I said to our medical director, I said, but they can barely walk. He said, I don't care if you have to carry them on your back. I want them to get out of the ICU and see that the world that they're going to go to. So maybe we didn't have the scientific evidence for therapeutic interventions, but I think Dr. Matlin, was his name, our medical director, was very insightful into this, because we know better today that medical interventions do better if you have the psychology behind them. Now, I got to tell you, I got no data to support this, but I think all of us who did ventilated patient mobility back in the 70s and 80s felt that it was the right thing to do. Now we have the evidence of that, and the evidence for all the other therapeutic and prophylactic interventions that Maria talked about. So I'll end up not on a dollar sign, but it's the right thing to do. It's why we're RTs. It's why we practice evidence-based respiratory care. And we need to do the right thing at the right time with the right devices, the right equipment, and us, the respiratory therapist. So that concludes my portion of the presentation. I believe, Mike and Maria, we have a few minutes for some Q&A.
Great, thanks, Gary. Yes, so let me transition back to my slides here. I'm going to invite the audience to submit some questions. So there should be a little call out button on your dashboard there, so you can submit questions for our panelists. In the interim, while you're doing that, while we're waiting for a few questions to come in, I had a few prepared, and I was interested in getting Maria's and Gary's thoughts on. So Maria talked a little bit about multidisciplinary teams for VAP prevention, but like a lot of our audience obviously is respiratory therapists. So if either of you could talk a little bit more about what role specifically RTs play in the care team, and possibly, in your opinion, what role maybe they could take a bigger role in, on the team.
The key is knowing the evidence that's going to help decrease VAP, and knowing that is the other thing that can help is educate other RTs, educate even our multidisciplinary coworkers, to making them aware of it, so we all work together through that checklist that's being recommended. Sitting our patients up, making sure we're monitoring our cuff pressures, that the recommendations of the subglottic ET tubes, that we're going through the checklist, SATs, SBTs, making sure we're completing them, and trying to decrease the incidence of VAP by these vented patients, getting them off the ventilator, even the sooner the better as well.
Yeah, I would second that, Maria. I think the first thing we need to remember is that respiratory therapists are the only healthcare professional who's educated and competency tested to deliver respiratory care. Now, that sounds like a lot like we're patting ourselves in the back. And I'll quickly say we can't go this alone. Without physicians and nurses and med techs and rad techs, this doesn't work. But make sure we're at the table when selections are made for devices, from medications, from cannulas to nebulizers to ventilators. Please don't let somebody without the clinical acumen that you all have make those decisions for us. And the reason is we know best. We don't have the knowledge breadth that a physician has, or certainly a nurse, but our depth of knowledge in our world is without parallel. So make sure we're at the table and make sure we're in a collaborative model. And then just to reinforce, what I found very enlightening of Maria's presentation was to look at the levels of science. If there's not sufficient validation, we just shouldn't do it. Doing something that doesn't need to be done at all, bronchodilator for all patients with ARDS as an example, it takes away your time. Time that would be better spent dealing with these individuals, not moderating the care, and I'm talking nebulizer treatments and PEP, PAP, OPEP, not moderating that by using protocols takes away the time that we desperately need, not just in these dire straits we're in today, but throughout our careers. It takes away from the time we need to invest. So maybe the answer to having staff mobilize patients is not in asking for more staff, but it's in stopping doing that which is not validated.
Okay, so we have plenty of questions coming in here. I'm going to try to get to as many as we can. I know we lost a little bit of time with some tech issues earlier, so we'll probably go 5 minutes over time if that's okay with Maria and Gary. But our first question from Megan, she asked, can someone please elaborate on best practices and protocols for oral care in preventing VAP? How often should it be done, methods and techniques, etc.? Also, why specifically not using chlorhexidine is preferable?
Great questions, Megan. I don't know if there's data actually supporting how often it should be done, the oral care, but so each hospital should have their protocols and how often oral care and brushing the patient's teeth should be done. The chlorhexidine, I think, is actually pretty interesting that it's being stated that it should not be used, and the claim and reading in this article is because it's showing it decreases VAP, but there might be a signal there, but that it's actually not a clear signal because the study wasn't a double-blinded studies, so they don't think it's a clear signal. So I think we need more studies to help, if we're going to support using it. Let me see if I can find the actual spot actually in the article even stating that.
Okay, so in the interim, another question, this comes from Tina. She asked thoughts on disconnecting the ventilator circuit for lavage, hyperinflation, and suction, and she said, yes, we have MDs ordering this.
Yeah, and other studies that have shown, lavaging our patients is not best practice. Increasing the chance of these patients actually developing VAP. There is a study actually stating that. So we've gotten away from doing that. If you need, hyperinflation, if we're trying to do recruitment maneuvers, those are things also we could do on the ventilator. There's other strategies that we could do on the ventilator.
Yeah, I think, and I'm surprised, maybe I'm not surprised by the order, but if you think back in the day, we would use tidal volumes of 12 to 15 milliliters a kilogram. And we thought that would give us the best compliance, the highest PO2. And when you think about it is just because you have a clinical improvement doesn't mean there's an ultimate outcome. And I think some of us, and maybe this physician, feels that we used to do this and it seemed to work, but there's no evidence. And I've learned so much listening to Maria talk about this. It just doesn't make sense. It's not worth the risk of opening the ventilator circuit.
And here is the answer to the chlorhexidine. Again, oral care with chlorhexidine has been studied in multiple randomized control studies, but the impact of oral care with chlorhexidine on pneumonia rates are unclear. The meta-analysis reports a significant reduction, but the signal is driven by unblinded studies. So there's no association between oral care with chlorhexidine and lowering VAP rates.
Okay, time for a few more questions. This one comes from Amy. She's asking, she's looking for what type of communication system you use for notification and tracking of patients for VAEs within your ICU. Is it manually tracking, or do you utilize software systems?
I think in every hospital that's being tracked by different teams, and I think most of them are doing it electronically tracked.
It's not a question, it's a comment from Nancy. She says, just a comment, it's harder to mobilize patients when there is so much isolation. Can't just take a patient isolated down the hallway, and rooms are very cramped. So I don't know if you had any thoughts on mobilizing patients, if there's difficulties and challenges for that.
Yeah, there is even a statement in the recent guidelines, even getting up the patient and even marching at bedside, just getting them out of bed, and just even walking in their little space, or just even marching in place.
Yeah, I think there's good evidence and there's good psychology probably supplanting this, but also sitting on the edge of the bed, getting to sit in the chair, walking around the room, it doesn't have the same impact from getting them out of the unit per se, but we certainly don't want to say they're in isolation, there's nothing we can do. That I certainly couldn't support.
It's not so much a question as it looks like it's more of a comment, and it's from Melissa. And she says, I work in post-acute care in the LTAC, acute rehab, etc. And we use the CDC's NHSN system for benchmarking and definitions. This takes into account case mix index, etc. It gives parameters. We have an infection prevention department made up of nursing staff, but we work really closely. And then HOB elevation and oral care were the top two things that we found made a world of difference. So I don't know if you had any thoughts on that.
Yeah, head of bed elevated and
oral care.
Yep, I mean those right there are the high evidence. So what we need to be doing to help decrease VAP.
Yeah, I would agree, and I applaud Melissa's organization for using CMI indexed. And what we have to, speaking of ventilator length of stay, when someone says our VLOS is 2.4 or 3.8 or 4.5, that's a meaningless number. What we need to look at is the individual MSDRG. It's not that what we're doing isn't making a difference in decreasing that, but unless you account for the patient acuity, be it the CMI or their individual MSDRG, you really can't compare improvement within your organization, nor can you benchmark it against someone else. So that's good to hear, Melissa, particularly for those respiratory therapists who work in LTACs.
Okay, last question, kind of just to sum up, because both Maria and Gary were talking a lot about how VAP care has changed over the years. So I'm curious what your guys' thoughts are on like how VAP care has changed, and then how it may continue to evolve in the next 5 to 10 years. If you have any thoughts on that, looking forward.
I think some of the things are we see a signal, but don't have the fact that it's actually decreasing mortality. We are seeing the decrease in VAP and some of the things I mentioned. So I think as more studies are being done, we'll get a better signal on some of these, and then being added to the recommendations.
And I'll add to that. I think we just, as therapists, whether it be VAP or patient response to nebulizer treatment or NIV or whatever it might be, is don't confuse lead measures and lag measures. And of all that one slide that Maria had were things we used to do that there's no evidence. If the patient improves after an intervention, that's great, but that doesn't mean they're going to come off the ventilator more quickly or out of ICU or decrease length of stay. So we need to separate lead and lag measures. Last thought I have is follow the science. It changes almost daily, particularly with these critically ill patients. So follow it, understand it, read the literature, join the AERC if you're not a member, by the way, and read Respiratory Care Journal. And as the science changes, use our communication tools within the AERC to let others know. So, thank you.
Okay, everybody, that wraps up our presentation today. I wanted to thank Maria Madden and Gary Kaufman for joining us today. Once again, this webinar was sponsored by Draeger. Thanks to Draeger for their support today. And again, thank you to Maria and Gary for joining us today.
Thank you.
Great. Thank you so much.